Good morning, everyone. Buongiorno a tutti.
Hello, good morning. Good morning. Okay, welcome to the third appointment with this webinar about fascia with our expert Enrico Dazzan, Mauro Torrin. Today we are going to talk about the fascia tools used on the upper limbs, and while the next appointment will be on spine. Okay, so that is related with the fascia tools. I think maybe we can give another 2 minutes to wait for the people to join us, and then we can start. So,
okay, we have today two special guests. From you can switch on the cameras. We have two special guests. One from Greece. Welcome, Malvina. She is the specialist of TECAR THERAPY GLOBUS on Greek market. And from Portugal, welcome, Marco. He is one of our specialists of GLOBUS TECAR in Portugal. Both of them are very well, they have a very good knowledge of our technology, but especially they use daily their own activity and things. So it's going to be very helpful to have them with us today for cooperate with Enrico as I do every week. So 2 minutes again, and we will start with the webinar. Thank you.
Right. So, see you soon.
Good morning, everybody.
See you.
Okay.
So here we are. Good morning, everyone. So that's the third appointment. I'm very glad to be here. Today we're going to speak a lot about shoulder, a lot of pathologies, a lot of practical examples. We're going to go with a brief introduction, an overview about the principle, the basic principles. Malvina and Marco, can you hear me? I would like to talk with you right now. Hi Malvina. I would like, if you can.
Hello.
Ciao. If
Ciao,
you can,
good morning.
yeah,
Hi,
just do
Malvina.
a brief introduction of you.
Hi, Marco.
Okay, so Malvina, please introduce yourself in just 1 minute, 30 seconds. Okay.
My name is Malvina Kourakou. I'm a physiotherapist. I am from Greece. I work, I have my own clinic, and I also work for a tennis club, which is called Tattoo Club. We have organized Davis Cup, Fed Cup, and big tennis events. So I had the opportunity to work with tennis players, and I work a lot with shoulder problems and upper limb. So it will be a nice chance to talk about all these topics and to do some to see some things with TECAR and fascia tools and all those techniques.
All right. Thank you very much. Thank you.
So I'll be here with you, and I will try to help the conversation.
Great, great. Marco, can you briefly introduce yourself, please?
Yeah. Hi guys, I'm Marco Teodoro. I'm a physiotherapist and coordinator of One Clinics in Lisbon. The One Clinics is a large group of clinics in Lisbon. Works about the last 10 years with sports athletes, volleyball players, basketball players, hockey, and so I will try to ensure we have a good experience with the upper limb, and like Malvina, we try to help Enrico to share my experience in this case.
All right. Great. Thank you very much. I know you are experts of upper limb. For this, we are here for share our information. I would like that this webinar would be like those before, something like a conversation, something for share our knowledge, our expertise with manual skills, exercise, rehabilitation. We're going to talk about this. We know that on shoulder there is a lot of things, a lot of things to do. All right, so I can start with a brief introduction of what we are going to do today. So let's talk about the menu. You know, we are always Italian, so we always want to speak about food. All right, we're gonna do just a brief recap on the PGE method. Once again, because I asked also to Malvina and Marco yesterday, and they told me that it's very important to repeat the basis of this method, of this technology, because with the right methodology, we can really achieve the right and the great results. We're going to speak a bit more on the introduction on the Yastumen. That means instrumental assisted soft tissue manipulation. A bit about the functional diagnosis and clinical reasoning, also for shoulder problems, and of course some practicals around the upper limb pathologies, with an integration also with the hands-free method. So we have already spoke for many times about this method. Just remember, keep in mind these three variables: the power, the geometry, and the electrode. What about the power? We already said that there is a therapeutic window between 30 and 42 degrees Celsius. And we have to understand that if we want some biostimulant effect, we want to reduce the pain, but without the production of heating, we have to choose the first window, the green one. Okay, so we are always between the 30 and 35 degrees Celsius. I was speaking. I did some examples using an infrared thermometer. Maybe I can show you very close to you. I don't know the focus if it's working, but for example, we have a very easy understanding of the temperature of the tissue temperature with an infrared thermometer. So it's helpful for our day-by-day job, especially for the beginners in the early stages of learning, and also we can use our hands for put the hands over the patient and perceive the temperature of the tissues. The other window is between 35 and 38 degrees, so it's a thermal effect, very good for oxygenating the tissues, for doing, for example, a massage, or for drain the lymph nodes. Also is the window for the stimulation of the fibroblasts. Maybe later we will speak this when we want to talk about the frozen shoulder, for example. And then we got the hyperthermal effects between 38 and 42 degrees Celsius. This is when we really want to go to a fibrosis. Imagine a chronic frozen shoulder with no pain at all, but with a very fibrotic tissue of all the capsular tissue. So we were speaking about the geometry. Vediamo, non funziona più questo. Benissimo. Okay. The geometry and the electrode. Okay, the complanar geometry and the opposite geometry. And we spoke about the electrode type and size with the capacity. Keep in mind that always we are in a superficial layers, okay, depending on the size of the electrode. And on the other, with the resistive one, we can reach the deepness of the tissue in a different way. We can reach the superficial connective tissue with a small one, or we can reach the deepness with the biggest one. I want to show these topics with the help of Federica. I will zoom out, per favore. Ti metti saluta con le gambe di là. So, for example, thank you for coming, first of all, Federica. Okay, go back, speaking about the geometry, first of all. So, complanar or opposite geometry. I got a machine here close to me. Some examples also on the shoulder for make you understand how to set up a complanar or an opposite geometry also for a shoulder. We can put the plate under the bra, for example, in a sitting position. We can use a band, an elastic band, okay, that we got on the kit, okay, of the machine. We can fix it. Of course, we need a bit of cream, okay, between the plate and the skin. And here we can use with, for example, a simple complanar geometry. Ragazzi, se volete fare uno zoom qua ce l'ho. I'm asking to the guys if they can show us something directly on the machine. Okay, here we can choose directly the modality. I start again from the home page. So I could navigate through the Atlas, for example, or with a free program. For example, with the Atlas, I can choose the shoulder, all right? For example, acute tendonitis. I got a capacitive and a resistive phase. Meglio se chiudi mi sa. Capacitive and resistive phase. If I tap on the first one, I get a description of what I should do, what I could do, and also some images of the positioning of the plate. As you can see, in this case, it's under the forearm, under the scapula, under the lateral part of the back, or as we did right now on the posterior part of the trunk, could be here in the middle of this of the scapula, for example. Okay, let's start the treatment. I said we are in a capacitive mode, 470 kilohertz. Okay, so I set up, for example, 50% of power, and let's see what happened. Okay, I start, for example, here. Devi chiudere tutto questo. Quella lì, l'ultima. Okay, we got 200 milliampere, as you can see. We are just starting to relaxing the tissues in the, for example, deltoid area. Okay. Okay. So I'm gonna just doing this for a few seconds, just for show you also the histogram on the machine. So please, Mauro, if you can do the zoom on the machine again, we can have a look on the, thank you very much, on the histogram. As you can see, is a green one. Okay, now we are more on the yellow window. This helps us to really focus and understand what are the biological stimuli that we are giving to the tissue. Okay, so more or less we are on the second therapeutic window between, we said, 35 and 38 degrees. Okay, so the histograms that you can see where we have the milliamperes of the current flow help us to understand the thermic sensation. Okay, Federica is perceiving a 6 in a scale between 0 and 10. So his, I can say, thermal sensation is a 6. And have a look here, please. Maybe I can put the thermometer. Okay, I can show you we have 37.2 degrees. Okay, perfect. So what's going to happen if you're doing, for example, a resistive treatment? Okay, I'm going to change on the second phase. Okay, just imagine that I've really relaxed the part, and I want to go more on the second phase, the resistive one. So I can just have a skip on the second, the resistive one. I start with the resistive. I set up, for example, 50%, same temperature. Okay. I want to show you this. I put just the electrode here and have a look at the histograms. What's going to happen? Okay. As you can see on the histograms, we got a yellow histo, and now it's becoming red. So it means that the temperature is going to increasing. The current flow is quite to a, I can say, thermal window. Okay. So it's around 600 milliamperes right now. Okay, now, zoom out. I'm treating here the tricep area. Okay, what happened to the histograms if I treat, for example, the distal part? So I'm using I'm increasing the geometry. Okay, so have a look also to the histograms for better understand what is gonna happen with this geometry here. And as you can see, again, we go back with the lower levels of current because we increase the impedance through the plate and the electrode. So the thermic effect with the same average that we set up of, in terms of power, we set 50%, 51%, and now are lower than before. So I go back on the triceps, and maybe you can have a look of the increasing of the histograms again. Exactly. Have a look at the 800 milliamperes that we are going to producing. So depending on geometry, okay, with the same amount of power, we can have different thermic effects. Okay, I hope this could be quite clear. I want to ask to Marco and Malvina if they agree with this, if they can, if they agree, or if they have any questions about this. Malvina, please.
I agree, of course, but I think that it might be a good idea to change the position and to go on the side, so you can work better the tendons there, or also to work with the shoulder plate and try to mobilize a bit the area.
Lovely.
Yeah.
Okay. This was just an example for better understand the current process and the changing with the geometry. As you perfectly said, we can combine this technology with the manual skills. This was what you were talking about, isn't it?
Yeah, exactly. Basically, I never. Yeah, it's not usually to use the seat position for the patient because I like to use, like Malvina said, a side lying position, or lay down with the belly down, the plate under the belly to work the posterior muscles or the anterior ones, to apply some techniques, some stretching, and it's very good, and we obtain very good results as well.
This is one of your positioning, for example, side bending with the plate under the
Yeah.
under the arm, or where you put the plate?
If I want a relaxing muscle, I use in that form you use. But if I want to apply some mobilization, I put under the belly.
The belly, okay.
Yeah. I know we will increase the distance, but to increase the power, we have more energy to apply.
So you're doing some mobilization in this way?
Yeah.
Okay. So you're catching the, I think the resistive electrode on your hand?
In my hand, and the other one apply the mobilization.
All right, like this, for example.
Yeah, for example.
Okay,
Yeah.
so you can perform the mobilization. Okay, now I'm sorry guys, because I am on the back part, because I think something like this could be, Marco.
Yeah, exactly.
Okay, Malvina, what do you think about it? Are you using the same positioning, or do you have other suggestions, for example?
Yes, it depends from the how much the mobility of the shoulder, because maybe there is a possibility that the patient cannot have this position. It's not very easy to and comfortable for him. If it is comfortable, yes, I can use it. Otherwise, I might use the side position, lie on the side.
Okay, and where do you put the plate?
It's a good idea. I can use it, and you can also.
You put the plate under the arm or under the back?
If I want to work the scapula, I will put it under the back. If I want to work on the brace on the arm, I will put it behind the arm.
Okay.
In the middle, I mean.
All right.
Nico, we have a question.
Yeah.
Regarding the power that you should use.
Yeah.
So the question is, when you use 50%
yes.
of power, it felt that for the client, I presume he's a physiotherapist, the client spent a little pain the day after. So he decided to reduce the power to 35%. And this because he learned, when he came here, this physio, to be trained, he learned that it's not necessary to have such a high power like 50%, for example.
Absolutely, absolutely. The power that we set up is for achieving the thermal results that we want to be on, like athermic, thermic, or hyperthermic. So the amount of power depending on the single client, the single patient, depending on the degree of hydration, for example. There are some patients that are very huge, enormous, so we need a lot of power just for a small increase in temperature. With other people, maybe well hydrated, we need just small amounts of power for achieving the same thermal results, the right therapeutic window.
Yeah, I have a good example for that question. So, like Carl said in the first webinar you do, I worked about 2 years ago with a bodybuilder, and he have instability on the shoulder, the right shoulder, and she ended the training and comes to me to do the treatment. But I work with 80%, and he felt nothing.
Yeah.
No. So when I asked him if he drinks some water, he told me, no, I don't drink anything. So when I told him to drink 2 cups of water, now with the 40 or 50%, he already felt that the warmth. So it's important to do the evaluation of the subject to see how the main objective for a physio.
Exactly. Malvina, do you have any experience about this?
Something like that, no. It's impressive. The change of the hydration, how it can change the body reaction and how it reacts to the therapy. But my everyday practice, I always suggest to drink water before the therapy, and we serve them a cup of water. So we try to control this kind of problems.
Yes, yes, exactly. So perfect. So thank you very much for your experience. I'm going ahead with the presentation. So we spoke about the power, the geometry, also the electrode is important. We already said in the previous seminars. Okay. Don't want to spend some time around the frequency topic. Also, the frequency is important for achieving different levels of deepness on tissues. Okay. Well, what about the fascia tools? We started last time applying the fascia tools on the lower limb, and these are tools for detect and treat myofascial restrictions. There are the two blades that are more similar to the fascial abrasion technique, and the other ones, the DIACARE and the DIA-spine for mobilization. Great. I want to show you here. The DIACARE has, for example, two holes, one in the back, one on the handle, and we can choose different positioning of putting the cable depending on the technique that we want to use. If you want to do, for example, a treatment of a trigger point with a PA direction, orthogonal direction, is very easy to use the handle for grab the DIACARE, and to use the other hand for have the direction of the force. So it's very different between doing something like this with our thumbs and stay with a ischemic compression for a long time, also for save our thumb. Thank you, Mauro, for technical support. Okay. On the other hand, the DIA-spine is very good for PA mobilization on the spine. On Tuesday, next Tuesday, we're gonna have the spine section. But let's gonna talk about a bit of history that we already seen the last time. Is something that were 3,500 years ago, because these techniques that nowadays we are going to talking about is, we can say, a modern evolution of the traditional guasa. The guasa was a technique where the people used to do also on families for treating themselves, for reducing, for example, flu, headache, temperature, topics that are not straight related with musculoskeletal system problems. And the point is that we can really promote the healing of the whole body. At that time, they were using for scraping away the bad chi along the meridians. I know that there are a lot of people following us from Asia, and maybe they know more about me in terms of traditional medicine, traditional Chinese medicine. But for better understanding the relation between the tissue and the autonomic nervous system, we need to know just a bit about the fascia anatomy. So this is a very well representative image. We have the epidermis, the dermis. We get all these superficial retinacula here, these verticals that you can see here. And then we get the superficial fascial membrane, other retinacula, the deep retinacula cutis fibers. Then we got the deep fascial membrane, this one here. Then we got a layer of hyaluronic acid, the yellow one, and another layer of fascia. So we got 3 layers of fascia, 1, 2, and 3. The superficial, the deep, and then we start with the epimysium, that is the first cover of the muscle fascia. What you see here, all these ecchymosis, all this called petechia, okay, is like a rupture of the retinacula. Because when we do the treatment over here with the Yasm, with the tool, we're gonna have a sliding and also a rupture, especially when there is some fixed, there is no sliding between the tissues. So we are promoting these capillaries areas here, these veins and capillaries, to bleed till over the surface. And you see, well, this kind of redness, I can say. Okay, so with the just connected to the TECAR device, it is not necessary to reach this kind of stimulation. The stimulation could be very, very gentle, very pleasant for the patient, because we warm up the whole tissue and then we go to mobilize and treat exactly where there is the restriction. Here we got some anatomical images of the superficial fascia. As you can understand, it's very full of elastic fibers. It's very elastic and thin layer. On the other hand, we got a deep fascia that is that have an increase on the thickness, is stiff, strong as well. And then we got the epimysium over here that can cover the muscle. So the three layers, okay? Superficial, deep, and epimysium. Also, we got to understand the rule of the fascia, because the fascia is not just, I can say, a container. It doesn't give us our shape, but has a key role on the receptors, on the proprioception of our body. Here we can understand how the interior connective tissue, the fascia, is actually connected one to the other. For example, from the epimysium, we go back on the perimysium over here. Then we got the endomysium, which one here. Then we got the external lamina and the sarcolemma, that are all part of the same connective tissue. I want to tell you this, that when I was at university, there wasn't this kind of knowledge. We were speaking about just aponeurosis. It was just a container of tissues, but we know this importance that nowadays we understood about the fascia tissue. That's why we have really we understand that fascia is like our biggest sensory organ. Because it's full in mechanoreceptors. As I told you last time, we have this crazy Italian family, Golgi, Pacini, and Ruffini, that are the main represented receptors on fascia. Golgi, of course, for more involved on the muscular contraction. Pacini more for the proprioception. Ruffini is a slow adapting receptor, quite important on the pressure information, and the interstitial sisters that are half slow adapting, half fast adapting for pain, for also mechanoreceptors information. The fascia is really full of these mechanoreceptors. And here there is an easy, I can say, an easy overview for better understand how this tissue is connected to our central nervous system and also to our autonomic nervous system. So when we perceive a densification on tissue, we perceive something like a knot, some stiff point where we don't have the proper coordination also of the muscle, of the movement, and we have a densification on the muscle and tissues. We do the manipulation. We can do with our hands, or we can do with a tool. And we have a stimulation of the mechanoreceptors, and we have two different effects. One is through the central nervous system, where we have a reduction in terms of contraction of the muscle between the alpha motor neurons terminations. And on the other hand, we have the autonomic nervous system stimuli that can produce a hormonal response, hypothalamic tuning, a changing in the fluids in the tissues, straight in the tissue. That's why the traditional ancient medicine was working also, changing, for example, flu, headache, some kind of pain, okay, abdominal pain, just treating the fascia, just doing this strange red petechia. So it is something very interesting, I think, and I want to share with you. Last year with Francesco, at that time exactly, we were in Malaysia, and it was nice to know that a lot of people do this kind of things still now, and they are passed through mother to son, this kind of techniques. But now we are going to talking about I can say a modern way of understanding this technology. Have a look in here. what's happened, just 1 second, I set up the audio too, remove it, yeah. Okay, so this is what we said: epidermis, dermis, then we have a layer of adipose tissue, and then we have the fascia layer before to reach the muscle. As you can see, is a web. Imagine that is really full of receptors, and we need to have this lighting between the first layers and the muscle layers. Otherwise, we could have some trouble, some problems. Okay, so when there is a densification where we're gonna lose this kind of ability, this kind of sliding, and we're gonna perceive it, and we can treat with the tool. And by treating, we could restore the nervous communication between the fascia and the central or the autonomic nervous systems, and we can promote again the correct sliding. So I think this is a very nice animation for better understand what we are talking about, and it's very easy to understand. I know that Marco is a long time that he's using the tools, and I want to ask to him some of his experience, if he likes to use the tools, what his experience using the tools. Marco, can you hear me?
Yeah, I can hear you. Sorry.
Yeah, I know that you're using it since a long time, isn't it?
Yeah, before I know the TECAR, I use it with in sports in volleyball players, and that's a very good tool for relaxing or before the training or the practice, and the athletes enjoy it a lot because it's a different tool to use to restore some functional on the upper limb, the lower limb. When Globus produced the fascia tools for TECAR, with the heat promotion, we can allow us to improve much better that kind of results, because we can, without the TECAR, we can improve the heat we want on that tissues. So it's not a poor technique, but it's with the heat, it's more likely to restore some kind of functions for the athletes. So it's a very good job with fascia. So if you think, if you have a clinical reasoning for that purpose, it's a very good tool to use.
Thank you. Malvina, what's your experience with the tools?
With the tools, the thing is that when you don't have the heating feeling and the heating advantage, yes, is that it might be very painful for the patient, and also you need more time to work with the tissue, and maybe you have after an edema or the sensitivity of the tissue is not, you are not able to work the next day because of the pain or the bruises that might happen there. And when you work with the fascia tools and the TECAR, you avoid all this stuff. Also, the great thing that working with these I find out is that I can work the fascia tools and also with the fascia tools, and also to mobilize the area, because I can work with this as the resistive electrode. So if I want to do also a mobilization, I can hold the the tool and work as the resistive electrode, which is very good for the therapy because you don't have to change the probes, and you can do easier and more effective your work, and it's nice for the patient because you don't lose time, you don't let him to change the probes and all this. So I like it a lot.
Right. So you mean you have the capacitive on one hand, and on the other hand you got the resistive.
Yes.
Yes.
With the tool connected.
Yes. Yeah.
Okay. You, Mark, are using it with the same, I can say, philosophy, with the same concept.
Yes.
Okay.
Yeah.
Nice to know.
Yeah.
Okay. Thank you for your experience and for sharing together. So I'm going ahead, Habib. Why the fascia goes into dysfunction? Why we can have some issues, some troubles with the fascia tissue? It's very interesting to know that we have three main myofascial dysfunction: the mechanical, the chemical, and the psychophysical. I can say conditions that can really affect the fascia. The mechanical. Let's just think about an overuse, for example. Let's think about a tennis player, for example. I can imagine that for Malvina could be very often on his day-by-day practice an overuse of an overload, I can say, of some muscles, maybe the same muscles, maybe the right hand muscles, because as we know, tennis is an unilateral sport, so there is a kind of imbalance. So maybe we can have some densification, some I can say dysfunction on the fascia. On the other hand, we got the chemical one. So maybe we could have a kind of poor hydration, like we said before, that can also affect the fascia. So the fascia is not well hydrated, so is not conductive, cannot conduct the electrostimuli for the nervous systems, both autonomic and central. And on the other hand, just imagine the psychophysical topic. I mean, topics that could affect the people. Just talking about the posture, for example, if we got some posture problems, imagine a long sitting position, also can affect the shoulder. Imagine someone that stay for a long time in a sitting position with the shoulder pushed forward. Maybe we will have a densification of the posterior part of the capsula. Later we will speak about that with the GERD example, the glenohumeral internal rotation deficit. So we're going to treat and in a very easy way this kind of dysfunction. So posture, chemical, mechanical, there are a lot of points that could really affect this tissue. And here we go with the indication. Which are the indication of this treatment? Limited motion, pain-free motion, when we get some issue on the pattern of the movement, reduction of the range of motion, and a dysfunction on the recruitment of the muscles. There are really a huge of condition where we can use the YASTM with really several pathology. I think that the most, I can say, perfect pathologies are the myofascial syndromes, because we are talking about something quite chronic, and it's very difficult sometimes to achieve results. If we are just using our hands, well, it needs a lot of energy, because stiff tissue, chronic condition, very painful. I used to finish my day, my work day, with a lot of pain on my hands since I started to work with the fascia tools. Because the chronic pathologies are, I think, the right one for this kind of tools. Are there any contraindications? Yes, there are. Not so many, actually, like compromised tissue. So we need to have an integrity of the tissue, not open wound or infection or tumors. Well, of course, if there are any pacemaker or some electrical implants under the skin, we don't have to go just to do any mechanical direct treatment over there. And of course, the deep vein thrombosis, but maybe we can work around that area, but not directly on the affected vein. And keep in mind the cervical carotid sinus. So in the anterior part of the neck, okay, we got two the two cervical carotid sinus that are baroreceptors that can manage and really maintain the same pressure level, blood pressure levels. So we don't need to treat in a so deep way or with a lot of warm, or also exercises or manual techniques could affect this anterior part of the neck. So be careful, but you can treat, of course, just be careful. All right, let's go a bit more on the physiology and on the benefits that we can achieve with these tools. First of all, we can affect the cellular level. There are different studies that are proving this. This is, for example, an MCL. This is a rat MCL, actually. This is the uninjured. This is the untreated, okay? And this is the treated MCL at 4 weeks. So, as we can see, this MCL was in this condition, and after the treatment, I started to seem more similar to the uninjured MCL. So that's why we are promoting the fibroblast activity. We are promoting the production of collagen fibers, elastin, and growth factors, all that can achieve the healing process for our ligaments. We already spoke about the nervous interaction, so we are actually going to stimulate the receptors, and through the receptors we can achieve some results on the motor nerve activity. So we increase the vagal activity, we relax the muscles, okay, and also we get a kind of sympathetic modification on tissues. Guys, are you using the black roll in your day-by-day practice? Or like with maybe with a ball, you suggest to your clients to treat themselves, maybe some trigger points. Are you suggesting this?
Yeah, or the foam roll or a lacrosse ball, because it's more rigid, or a tennis ball I used to use on sports for the athletes, and they can manage ourselves to use at home or before the practice, because before the fascia tools with TECAR, we need to improve the athletes, the performance of the athletes. So it's the formal, it's a treatment I combine in clinic, so with exercise for stretching, and yeah.
They are happy to use it, or is it painful for them, or?
I never use it in the first or the second, or in the second session. I use when I reduce the pain significantly. So
okay, good idea. I think it's a very good idea.
Yeah, try to
so you
not to.
You increase the pain threshold, so reduce the pain, and then you suggest to the athletes or to the clients to do the foam roller. This is a very good idea, because sometimes they are very scared to do, because it's very painful.
Yeah, it's very painful. It's not so comfortably for them. So I use that ideologies to improve results. It's much better for them. Yeah,
Martina. So Malvina, sorry, are you doing the same, or?
Sometimes, as Marco said, we are not working from the first session with foam rollers or self-myofascial release tools. But when I use them, I try to have them warm up. So maybe they might run, for example, for a while, or do some stretching first and then work with that. Or after the therapy that we have already worked the area that we want to open, to release, that we have the area heated, is much easier.
Okay, okay. I've tried sometimes to do the hands-free treatment with the adhesive electrodes before preparing. So I didn't have the time, for example, with some clients to do the treatment before. So I just put the electrodes, the pads, for preparing the tissue, and then I asked the patient to do the black roll, for example, and the sensation was really different. Actually, we didn't promote a great increasing in temperature, but just a electron flow to the first layer, fascial layers, and they tell me that the sensation was not so painful as before, as usually. Have you ever tried this, or never?
No,
maybe
never in that way, because I use the hands-free mode after use the fascia tools, more for stretching and to promote some exercises. I never think about use the hands-free mode before the treatment, but it's a good idea. Yeah, I will try it the next time. Yeah.
Okay. Thank you.
Because there's a question.
Yes.
Can we use the tools in terms of fascia if the patient have a hip prosthesis?
Yes, of course. During last webinar, we were speaking about the lower limb. We had an example of the iliotibial band syndrome, and so the positioning for that kind of district. And also, if we had a prosthesis, a osteoprothesis, a hip prosthesis, because we can use it. So the point is, we are in a resistive modality, but if you remember the PGE method, we are with a very small surface here, so the current will stay very close to the electrode. So we are not affecting the prosthesis, we are just treating the first layers of tissue. I suggest you to use very close geometry. For example, you can put, for example, the plate as we did last time, just in the middle here. So the plate is here. You are treating, for example, all the lateral part. Okay, so you are gonna have in a very short geometry, an opposite geometry, and with the tool you are very close, okay, to the first layer. So no problems for the hip prosthesis, and it helps really a lot because there is always some ancient fibrosis when we reach to that point. So maybe the arthrosis, the arthritis that this kind of person has lived with. So for a long time with an arthrosis, all the area became very stiff, very fibrotic. So it's very easy to have good results. But now we are talking about shoulders, so maybe we go back to our. But thank you for your questions. Any questions, Francesco?
Well, there are always the same question related to the materials that the prostheses are made. For example, titanium or steel, ceramic can be used without problem.
Yeah, the point is normally we need to have a paper where the surgeon say us and certify what kind of prosthesis he is using. So what the prosthesis of that patient. Nowadays, all the prostheses are well conducting, so it should not be problem with the prosthesis. What I suggest to you is always to have a contact with the surgeon and share the treatment protocol. If you don't want to have issues, just use the capacitive mode. You can easily have great results also with the capacitive, that you are very sure to stay in a very superficial layers. You can work on the edema, you can work on the peri-surgical area, okay, so you're not affected the bone area. That's the way for be sure you're not in trouble with that. But if you have if you are sure that the prosthesis is just a normal metal, a magnetic one, you can use also the resistive. But it depends, of course. I suggest you to have always a very good relation with the surgeon and to share the treatment, the technology that you are using, the techniques that you are using. This way you achieve the greatest results and the great also approach.
Another question quickly.
Yeah.
Important is we use just capacitive, but should we just use the small electrode?
Well, the small, the medium, the biggest one, depending on the prosthesis. For example, if I get a knee prosthesis, I can use the medium one, or the smaller one if I want to treat just the peripatellar area. On the shoulder, yes, I can use the big one for example, treat the scapulothoracic muscles, or I can use the medium one. This is the 50 millimeter capacitive all around the area for yes, increasing the drainage and all the muscle contractors I can solve with the capacitive with the 50 millimeters. Okay. All right. So we were speaking about the cellular benefits, the nervous interaction. Okay, and then we are talking about the warming effects. As Malvina and Marco says just before, connecting the TECAR devices with the tools is a very big plus for us as a physio, because we can benefit from a lot of things. The warming effect, first of all, because when we increase over the 40 degrees, we can really modify the hyaluronic acid chain, so we can promote the famous sliding on tissue. But not only the warming effects are important, because we can also benefit from all the regenerating processes. We can benefit from the oxygenative processes. Also the ability of drain of the structures. So there is really a lot of things that we push together in one new technique, I can say. Also, as Malvina said, we have the reduction of pain for those patients. So the pain, the treatment is not so painful. I remember the face of my patient, some of them, when you are going close to them with some I can say blade like this, okay, maybe they are a bit scared, no? But when you start the treatment, maybe you do a preparation with a capacitive, and then you go directly with the tool connected to the machine, they have a pleasant sensation. We don't need to push a strong energy, we just need gentle manipulation of the densification area, and so they will accept in a very good way. So they like it sometimes, and also they have the results since the first session. So they really understand the benefits. All right, another one is the benefit for the therapist. Last time we were speaking about the pain on the thumb and the high prevalence of osteoarthritis for all the physios, because we work with hands and there is a high level of prevalence of osteoarthritis in physios, also at the young ages. Okay, this was a study with 24 people, 24 physio, but there are a lot of study. If you go on the on PubMed or where you want, you can easily find a lot of publications speaking about the work-related pathologies for physiotherapists. And we are talking about lumbago, we are talking about pain of the thumb, and there are several things that are going to happen, like the carpometacarpal joint laxity, the decrease in pinch strength. Okay, we have a loose, we lose the muscles of our thumb, of the tenor part of the hand. Okay, so having a tool is really helpful, and these are the techniques that really can do an aggravation of the symptoms, like the PA mobilization, the typical the basics I can see of the manual therapy. Okay, also a soft tissue massage, or the Mulligan mobilization, or the classical ischemic compression technique, like the trigger point pressure. Yes, one thing about this is talking about how much energy we can save. Well, by using the tool, actually you save 4 to 5 times your force, your energy. So it means that with pushing just 200 grams, you achieve 1 kilo of force on tissue. So we don't need to push great levels of energy, but just very gentle forces for achieving a force 4 to 5 times more higher. Okay, the last part is about the functional diagnosis and clinical reasoning. When we are using this technique, we always have to switch on our brain. Is the first tool to use, the first device, I can say. Is it a structural or it is a functional issue, a functional problem? All right, let's start with the structural. Structural could involve something more related to a lesion, to a fresh lesion, like could be a traumatology, could be a post-surgery client. It's very easy to find an imaging of the damage. On the other hand, if we're speaking about functional, it's not so easy to find something on an MRA, for example. So in this case, we are more related to acute inflammation, okay, acute injuries. In this case, the technique is to treat upstream and downstream the lesion. It means, for example, if I got a very acute lesion on the elbow, okay, just imagine I got a rupture. I got a rupture of the extensors of the wrist. So for sure, I'm not going to treating straight the area of the lesion. But what I can do is treating proximal part and distal part of the lesion. This is very important because what I can achieve is the relaxation of the proximal and the distal part, also the scapula for sure. I know that Marco is very I can say aficionated, is very well therapist also of the scapulothoracic area, and it's very important, but I'm not going directly on the lesion. Okay, this is when we are talking about an acute lesion. Let's go talking about the functional. On the other hand, we got the functional dysfunction, where we are talking about movement dysfunction, maybe something that is correlated with bad habits like bad postures or bad style of life. We are not doing, for example, the proper movement. If we're talking about some sports, we are not able to throw correctly or to catch correctly the ball. For example, if you're speaking about volleyball players or tennis players, and we enter on the functional, dysfunctional area. Okay. So on that, with this pathology, we can treat proximal, distal, and also on the pain side. So let's do again the example with the elbow. If we got a chronic condition, imagine a chronic condition where with a pain since maybe a couple of years, okay, really a long kind of a chronic one. All right, we do the correct evaluation. We have to understand the role of the scapula, the role of the extensors muscle, the role, for example, of the pronus supinators, okay? But we can treat proximal, distant, and also on the side lesion, directly with the tool, directly with the blade, no problem, okay?
Yeah. Is it expected to get hyperemia reaction while using the tools, or we shouldn't get to that point?
No, as I said before, by using the combination between the tool and the TECAR device, the DIACARE device, we are promoting the vascularization. We are increasing the oxygenation and the circulation on that area, so we don't need to break all the retinacular fibers. Could be, maybe if we have some very ancient dysfunction, very ancient, I can say, densification, we need to break it down a bit, okay, but we don't need to produce a big ecchymosis, okay? Sometimes, yes, but we don't need to. On the other hand, if you use just the tools, just the classical mechanical tool, you need to do a lot of energy to the tissue for increase the temperature level, and for sure you will achieve this petechia, this ecchymosis, okay? So I remember also Malvina said that you don't need to produce this kind of effects. You remember the slide with the Chinese medicine pictures, no? Where there was the old back part of the shoulder or the neck completely full of ecchymosis. No, we don't need in this case. Any other questions, Francesco? Okay, Okay, I finished this one before to start with the practical part. Just the last thing, the mixed between the structural and the functional. All right, in this way, if we have a bit of damage, but also a bit of functional, this is very, very often, very common. Okay, we start with the upstream and downstream on the lesion. So we are not going directly on the lesion. Maybe later, when we reduce the inflammation, we can also go in the pain side. Okay, guys, how are you, Malvina and Marco? Everything is okay? Are you still awake?
Yeah.
Okay, Malvina, do you have a glass of ouzo?
No, just water.
Okay. What about you, Marco? Everything's okay? Do you have a beer there with you?
No, just coffee.
Yeah, but we don't know what you got inside that cup.
Oh yeah.
Maybe it could be some, maybe gin tonic, you know.
Yeah, probably.
So, any questions on these? Also for you guys, any say about what we have talked since now?
Marco?
I don't know. I agree everything you said about that question of if you have a total rupture or a partial rupture, we never treat directly on the lesion, but we can go surround the other muscles to improve. So I like to work on this way because we have very good results if you start to treat the areas around the lesion, and you can apply some technical mobilizations, and that protocol, or it's not a protocol, that diagram you have there behind you, it's exactly that way. So you need to specific to know how where you're gonna apply the fascia, how to use the frequencies of the device. It's a very important thing. I know when Carlos do the workshop, that's a question that we need to answer. Why or when to use the different window of frequency. Yeah.
Okay.
So I think it's important to explain people when to use that kind of frequency. When I use 400 or when I use 1002 hertz, because it's the main purpose of the TECAR device. It's to know which frequency I use to a lesion to treat.
Okay.
In fact, about that, it is a very interesting question, and is asking which one is the frequency that you use when you use fascia tools.
All right. I would like to answer to this. Maybe later, you guys, I want to show you something just for a brief example for who are following us from home. So, please, Federica, have a seat here.
Sorry, Malvina.
Here, very quick example could be this. So we did we need to use the proper cable, all right, connected to the machine. Remember that is the same cable that we are using also for the automatic treatment. Okay, can you also have a zoom here on the machine, maybe? If it works, let's have a look. Seems maybe yes, no. Great, almost. Oh. Can you see? Great. Okay. So I select fascial treatment. Okay. So very easy to understand. Fascial treatment. Here I got the possibility to choose the frequency, as you said, from 400 kilohertz, 470, 700, sorry, 1000 and 1000.2. If we are talking about hard tissues like tendons, Like for example, I would like to show you an example on the patellar tendon, for example. And I know we are a very dry tissue, quite superficial, okay? It depending if we want to treat, for example, the back part of the tendon or the superior part of the tendon, for example, a bursitis, for example. So I can choose 400 kilos if I want to treat the deepness, or 470 or 700 if I want to stay more superficial. I then suggest you for tendon purpose to use the 1000 and the 1.2 because are very, very superficial. This could be a good idea by treating some problems with the scars, for example, more in the epidermis layers, okay? But if we want to treat the tendon pathologies, we can move from 700 or deeper, 470 or deeper again with the 400. For example, I'll show you here an example. Imagine a bursitis. I work with the 700 kilos. I tap here on OK. I set up, for example, 50%. Let me use the gloves. So the sound help us to know that the circuit is not connected right now. Give me just 1 second that I put the gloves. Okay, I use a bit of cream and I can start the treatment, for example, on the anterior part of the tendon. I don't know if you can see me. Okay, so I'm using the 700 kilos working directly on the tendon. Okay, so this is an example of using different levels of frequency. So for the deeper layers, I will use the 400 and then 470 or 700 kilohertz for the superficial layers of the tendon. The same, of course, for the shoulder. If I want to treat the long head of the bicep, for example, the long head of the bicep, I can use 470 because it's a medium depth tendon. And I want to ask to you, Marco and Malvina, your experience, because working with frequency needs a bit of experience, of course, need to be to well understand the tissue physiology and so the sensation. What's your experience about this?
You can go ahead, Malvina.
Okay. At the shoulder, that the tendons are more superficial. You can palpate, or you can use techniques also with ISTM tools to work to put it in a stretching position and work on it. It has very good results, and you can imagine that the patient, after he doesn't feel any pain, the mobility of the shoulder changes a lot because you can go deep, you can work very specific, and it's very helpful the fact that you use also the thermal energy, so you can work in a very good with very good results. What I'm doing is that I go with 470 or 700, depending on the area and the muscle of how big are the muscles that I target. For example, if someone is has a lot of muscles or is fat, it changes the way that I'm gonna use the frequency.
Okay.
There's also another question, quite interesting, about what is the correlation between the frequency and the power, Enrico?
Okay. Can Marco maybe answer?
Sorry?
Marco, the question is, what is the correlation? What is the relationship between the frequency and the power in the use of fascia tools?
So we know if you use a lower frequency, we want to be more deeper. And for me, it's like Enrico said in the first place, in the start of the webinar. It depends of the distance we put the plate and the electrode or the area we are treating, because I don't need much power if my plate and the electrode are too close to each other. So I can increase the power if I increase the distance of the both electrodes. So if you treat the person with the oppositive geometry, if the plate is parallel to the electrode or the area, if I use, for example, a 400 or 470 frequency, I don't need to put some. I don't need to increase the power of the device, because we can increase the deepness of the tissues. Maybe we can treat 15–60% of that power, and we will expect some good results.
Okay, guys. So
I don't know if I answered the question, but
yeah, for sure, Marco.
Yeah.
Francesco, other questions from home?
No, for the moment.
Okay. All right, we go ahead with the practical part. Just a brief recap on what we are doing right now. Okay. So maybe you can have a look at the screen where we got a 3D anatomical atlas, where we can show this model here. We are going to have more on the deep part of the muscles. So, shoulder. Right. Remember that we are talking about, starting from the bones, about 5 joints, okay? So we have the scapulothoracic joint here, we have the glenohumeral joint, the supracromial joint, the sternoclavicular joint, and the acromioclavicular joint. So 5 joints, 2 are functional, the scapulothoracic and the supracromial, and the other 3 are real joints, we can say. Just a very, very brief recap. Keep in mind that we are talking about rotator cuff. The rotator cuff are the teres minor, the subscapularis, the infraspinatus, we can say, sorry, the sorospinatus, and then we get the subscapularis. It has a very interesting view with this amazing 3D atlas. Okay, so it's under the scapula. These are the main 4 muscles of the rotator cuff. Of course, we got the participation of the long head of the biceps. Here we got it. Okay, and on the other hand, we got all the muscles between the scapula and the trunk. So here you can see the major rhomboid, and I can show you. Also, we got the upper serratus over there. We have also the anterior serratus. Let me show you. Here we are. The anterior serratus, also from the medial part of the scapula to the trunk. And then we got the most known muscles also, I can say, at the gym, okay? So the trapezius medius, lower trapezius, upper trapezius. So always we have to have a very clear imaging of the anatomy, especially when we are doing fascial treatments, because we are working, as you can see here, this very nice picture, the white area, okay? The white area is the fascia connection, is the transition zone between the muscle and the insertion of the on the joints, on the bones. Okay, so let's do also something with the GERD. GERD is the glenohumeral internal rotation deficit, so we can easily evaluate by fixing the scapula and evaluate if we have a losing of the internal range of motion of the glenohumeral joint. Federica, well, she's perfect, so doesn't have this kind of problem, but with that kind of patient, you will have something like this. so you cannot reach the full internal rotation of the glenohumeral joint. So that could be very frequent, I think, in your patient, Malvina, for example, throwers, tennis player, volleyball players, all the overhead sports, when they have to do throwers, okay, throwings, maybe you have an increasing on the external rotation, but you got a limitation on the internal rotation. This is due to a very tightening of, very important tightening of the posterior part of the capsula, or maybe a shortening of the external rotators, okay? So let's have a look at Vieni con la spalla fuori. Lasciami mettere questo sotto, scusa. Okay. So this is one of the positioning that I use with my patient, for example. Face down, I put the blade under the belly. I have all the posterior part of the scapula here, very, very close to tree. As you can see here, we got the scapula, okay? So it's very easy, very clear, very well represented, all the posterior part, if we don't have pain, of course, because the patient has no pain, otherwise we need to use other positioning, maybe with the arm on the back. So I can use the DIA blade large or the DIA blade small. I show you just a couple of techniques, okay? So very easy, we prepare the area with a capacitive. Maybe I can show you just a few seconds. Can you zoom on the machine, guys? Just for have a quick understanding. Forse devi andare a spegnere la luce. So free program, quick start. I put capacitive. Let's start with 50–60%. Federica is very well hydrated. It has a perfect conduction. Okay, so what I'm doing right now is promoting increasing of vascularization on the posterior part of the capsula, so teres minor and infraspinatus, also as the muscles of the posterior part. Okay, we don't need so many time. Okay, just few seconds. We start to see some swelling on the tissue. We can talk to the patient. What's your heat perception? Quanto sentite da 0 a 10? Okay, she says 3, between 0 and 10. Have a look also on the histograms. What the histogram says to us is a green histogram. So we can increase the power. Okay, so I put 70–80%. Okay, 80%. Let's go when it happens. Always have the contact with the patient. We can always ask to her about her sensation, how her thermical sensation. Okay, she says 5. Okay, so we are just promoting a bit of warming on those tissues. Also, by promoting the warming, I also have an idea of what I'm treating here, because I can perceive also the posterior part of the deltoid with the edge. I'm starting to having an idea on my brain of all the tissue in this area. I can also warm up a bit the supraspinatus area, the levator scapula, all the areas that I really want to treat, and also the part between the scapula and the trunk. So for the scapulothoracic muscles, because these are the muscles that I would like to treat, posterior part of the scapula, and maybe also the scapulothoracic muscles. So have a look of the histograms there. We are using 300 more or less milliampere. All right, now he's perceiving a 7. So I think it could be okay, could be enough. I would like to show you the temperature of those tissue. All right, in really few seconds, we reach the 37 degrees. Sorry, okay, 37.7. So we are exactly on the second window, okay? And you can see also the color is starting to be close to the red one, okay? So after the preparation phase, just imagine a couple of minutes doing this preparation of the posterior part of the shoulder. I switch to the resistive mode, and I select the fascial treatment. Okay, I select the DIABLADE large, resistive, fascial program. I leave the normal 470 kilohertz is okay for me. Okay, I start with 50% of energy. Okay, I put a bit of cream on the edge of the tool, and I'm starting with just scanning on the posterior part of the scapula. Very gentle, very flat. Okay, I'm not pushing so much. We can have a very light improve on the hyperemy. I find here there is a bundle, a quite fibrotic bundle here. Here we don't have a real GERD, of course, but before to do the manipulation, the mobilization, I start to release the tissue. After I can combine also with the kinesiotherapy. So this could be an interesting technique, and that time by time I can go more deep with the edge, with the straight edge, okay? Changing and tilting in this way the tool. So from a flat position, I move to a more angled technique. And as you can see, the area that are treated are more hyperemic. I don't know if you can see here with the camera, there is a bit of red here. No petechia, okay, no petechia, but a bit of increasing with the hyperemic vascularization. Okay, so by the way, I can use the DIABLADE large or the DIABLADE small. Let me change that one. It is more specific. Let me take a chair, please. More specific, and I can reach the specific bundles, okay? I can really go through the limitation of the posterior part of the scapula, or the capsula. I can do easily in a sit position, or I can use in the other way, for example, standing in this position. And here, with this rounded edge here, okay, we are gonna go more deeper on the tissue because we are not using a inline edge, but we are gonna use a rounded, focused edge. So here there is the bundle, here there is the densification, exactly under the acromion. So we are exactly on the posterior part of the capsula. We are not on the muscles, okay? We are exactly here on the capsula. And I'm doing just a very light capsule manipulation. With the energy, we are using a 500 milliampere. So we are on the yellow window. Does it pain?
No.
Okay, no pain for Federica. Nice to know. Senti un po' di caldo? Okay, if you want to warm the tissue, what you can do is just to stay in a fixed position. You put the electrode in a fixed position, flat. So you are using like a normal resistive electrode, okay? So you don't need to change with the traditional electrode. You just stay here. You wait until you reach the right temperature level, and then you go again treating the posterior part of the scapula. Okay, guys, so this could be done for just a few minutes. We don't need hours of treatment because in few seconds you can retest the patient and have a look how you can improve the internal rotation range of motion. Okay, I want to show you something more. Then we can ask to our friends, our specialists, their own techniques. I want to show you something for the scapula. I hope Marco could enjoy this technique, because as we know, the scapular rule is a key rule. We are talking about dyskinesia. Not only the glenohumeral joint is the target for the shoulder problem, but mainly I can say the roots are always on the posterior part of the trunk. Okay, so I want to show you this. Oppure guarda, vai un po' all'interno. Okay, with the dia blade large, I don't know if you can see what I'm doing. I reduce the power to 20% because I don't want to move the dia blade. I want to move the scapula, so I stay in this fixed position because maybe I want to release the rhomboid, the superior serratus, and the trapezius medial. Okay, I'm using my hand here. Okay, what I'm doing is just a mobilization anterior and posterior of the shoulder with the blade always in the middle, always in the back part. I'm sorry that maybe you cannot see, but what I'm doing is this.
We can see Enrico.
Oh, okay.
Very good technique, my friend.
Okay, so this is very useful because you don't need so much energy. You don't need to scrape the tissue, but just you fix yourself. You stay with the blade under the scapula, and you can reach the deepness of the layers, and you can easily mobilize the shoulder upward. Or later, of course, you can also have other techniques, putting, for example, the blade on the back part of the scapula and doing, of course, some more glenohumeral movement. Okay, guys, please, Malvina and Marco, give me your examples or your experience. Share with all the thousands of people that is following. Well, a lot of people is following. Really hundreds from a lot of different countries. So please.
It's very nice. It's very good technique because we can work the shoulder plate and we can work the posterior muscles. And also, if we want, we can also work with the, as we said, with the resistive electrode and do some movements also for the. The patient can do energetic movement if we want, or we can do passive mobilization. It's very good, the position, the geometry, and the way that we can work at this position.
I agree with you guys. Yeah, it's a very good position to work in posterior muscles of the shoulder, because we have a lot of range of motion and a lot of amplitude for us therapists, and for the patient we can improve different things, because as you know, the shoulder has the most complex articulation of our body, so we can reach different parts of the glenohumeral and the posterior and anterior muscles. So I like a lot that kind of the scapular mobilization during the treatment with the fascia tools, because of course when we have a GERD or a rotator cuff tendinopathy, normally we have a dyskinesia of the scapula. So for me it's important, well, it's my opinion, but I start always with treat or relieve the rhomboids, then I go to the capsula, and then I relieve the other muscles.
So you start with the scapula for the posterior part, for the
I tried most to redirect the scapula then innervate the trapezius, the superior trapezius, because we have a lot of activation and inhibition of the inferior, like that. So I try to correct, to show some corrective posture, and then I will start to treat.
Good, great, Marco. Great approach, I think. And I think it's very important to share the experience, because we can keep in reasoning, and I think this is a very great approach, starting from distal then to proximal, because the scapula has a really key role on all pathologies of the rotator cuff.
Yeah.
There's a question, Enrique, about if the patient will feel a higher level of heat when you are treating the part that is as the issue, the pathology, rather than the part that is of the body that is healthy. So when you are moving the fascia tools on top of that specific point, will the patient feel a higher level of heat or not?
Under the blade, you mean?
No. When you're treating let's say, the injured area, let's say, okay, when you have the pathology, will the patient feel a higher level of heat in that specific area, or it will be the same that if you treat a healthy part of the body? No. Is there anything correlated between the injury and the level of heat that the patient can feel?
Well, of course, if there is an acute injury, it's not a good idea to induce a very high level of temperature. It's better to work in the surrounded area. Okay. Of course, when you're using the fascia tools, as we said before, depending on the bars, depending on the histograms, we can produce different levels of warming effects. If you're working with an acute injury, I suggest to use low levels of histograms, like, for example, the green one. So you're promoting a regeneration without increasing so much the temperature in that area. Other ideas for you guys?
Sorry, I don't understand, Enrico. Sorry.
So Malvina, do you have other ideas around this?
To change position, we can change to go on the side.
You mean about this
position?
Yes.
But yes, if should do.
Malvina, your answer is not very good. Okay. Malvina, we can't hear you very well.
Yeah.
Try now.
Now? Can you hear me better?
Delay, but we can hear you now.
Okay. Maybe we can work differently. For example, if we can work with at the sideline position, or we can work with the hands free if we want to do some exercises. Also, if we want to have the whole upper limb chain, we can work with the resistive electrode and to increase the power, so we can work the whole arm. And for example, we can hold the electrode, the resistive electrode, and do the movements. I mean, different ideas that you can work the pathologies of the shoulder. That might be more holistic, or not only with the fascia, I mean, technique.
Yeah. All right. Thank you, Malvina. I want to show you something. I'm doing this kind of mobilization here. As you can see, with the DIA blade small, I'm treating all the triceps and also the fascia between the bicep and the triceps, the inferior part of the capsula, a bit also in the latissimus dorsi, okay, I want to show you that I put the plate under the trunk, so I have a quite long geometry actually. But have a look at the histograms. Have a look on the histograms that we start with the green, and now we got the yellow one. The yellow maybe is not the right window that I want to promote, so I increase the energy through, for example, 65 or 70 also. I can show you just for as an example, because maybe I want to target on the red window. I want to increase a bit more the temperature, and depending on the geometry, because now I set up a larger geometry, just wait a few seconds. I'm treating again the same area, the posterior part of the tricep, and I'm starting to okay. So the values of current are increasing, okay, are more than 600 milliampere. Okay, have a look right now what is gonna show you. Okay, we got the red one. Okay, we are starting with to increase the histograms, so we are definitely in another more higher, I can say higher therapeutic window. So always have a look on the screen, ask to the patient about the perception of the temperature. You can also touch with your hands. In this case, I'm using some kinesis for recover, for example, the full extension of the shoulder. Okay, this could be, for example, a late phase on a capsulitis. Okay, a frozen shoulder. Guys, can I ask you something about the frozen shoulder? Are you using these techniques on frozen shoulder? Marco, for example?
Yes. On the first place, I use a supine position because most of the frozen shoulder I treat, when they come to me, already have a very higher limitation of the range of motion. So it's very difficult for me to do some kind of mobilization. But I start with the capacitive mode on the at least 5-10 minutes. Then I use, like Malvina said before, the resistive mode, but with the electrodes, not the fascia, because I need to release and relaxing the deeper tissues, because on the shoulder we have superficial muscles, but as well deeper muscles. So, and I try to improve, first of all, increase the range of motion a little bit. As you know, if you start to manipulate or to mobilizing the shoulder, we can decrease the pain. So because of the physiopathology associated to this kind of movements. But I start with the supine position. That at the end of the treatment, I use the fascia tools to improve and redirect the fibers to improve the correct or to the muscle start to contract at 100%. But always with the mobilization techniques, always the frozen shoulder, because actually I did an article for the university when I study about frozen shoulder, so I like a lot of this pathology. Yeah, okay. I like a lot of this pathology then, but in the second session, I use the sideline position because I can put the arm of the patient. I don't know if you can see me, but put under your body, but on your shoulder, Enrico.
You mean
you
over
put the arm in your own shoulder.
Yeah, sorry, my shoulder.
Yeah. Put our arm under your, yeah, exactly. I put the electrode on the other, yeah, and I can slide with the fascia and actually mobilize the scapula at the same time. So exactly. It's a very good technique for me. So, and then we can mobilate the scapula, redirect the fibers, know and understand if any trigger below our fingers or below the fascia tools, so we can improve a lot of movement in this kind of pathology.
Great, great.
Yeah.
You said what I did.
Sorry?
Have you seen what I did? I don't know if you're using, but this is the hands-free. I want just to see you on the screen here how to set up this kind of treatment. I put the plate under the side, the lateral side, and I put the small plate on the posterior part of the humor. Also, I could use the adhesive, but for today I decided to use the fixed one, so we can go easily on the hands-free section on the screen. Okay, hands-free. I can set up medium to long geometry because there is quite a big geometry, so maybe a long geometry could be good. And I start resistive for 170. I don't want to. I want to go quite deep, and I set up 50% of power. Okay, and as you suggest me, I was doing kind of manipulation and sliding on the scapula, and also I can go down with for stretching the posterior part. I think you were supposing something like this.
Exactly.
Okay.
Yeah.
So here I benefit from the current through the plate. Yeah, from here. So I'm warming up all this part, especially this is a resistive one. So especially I'm involving the connective tissue. Okay, so the most resistive part. In the capsulitis is very well. It is a kind of scar tissue, we can say. So it's very useful. Lo senti? Okay, guys, any other ideas for treating other pathologies of the shoulder? Malvina, tell us about your experience with, for example, tennis player. What is the most, which are the most common pathologies for tennis playing? Like tennis elbow or what's more? Wait, si atenta.
Deve attivare su
audio. We can't hear you.
Now?
Yes.
Okay. The most common, you mean from the shoulder? The most common problems?
Upper limb.
Okay. In general, I'm working at the tennis club, so I have a lot of tennis elbow syndrome. And also maybe some the carpal syndrome that we show. Okay. Maybe it's a good idea because there are a lot of people that are suffering from carpal syndrome.
I want to ask you a question. How you manage generally? I mean, just the basics of your tennis elbow. I mean, management. What are your main the strong points of your recovery process of the rehabilitation? Malvina.
We do the evaluation first. We have to check if something's going on with the joint or it's just the tendon, because sometimes it's not only the tendon that has, for example, scar tissue, or depend on the face of the
We can't hear you. I got a question for you, Malvina. Can you switch off the camera? Can you switch off the camera just for a second, so maybe the audio connection will be better? Oh, perfect. Thank you.
Now?
Yeah, better. Perfect.
Can you hear me better?
Yes, great.
Okay. So what I don't know where I led you. What I was saying is that we evaluate the area, we see, we check in which stage of the pathology of the syndrome we are. We can evaluate the joint and if something is going on also at the wrist, because sometimes the wrist has to do with the tennis elbow. And then we focus at the area that when we want to treat. If we want to treat the specific tendon, we can work very good with fascia tools. If we want to do a mobilization at the elbow, we do hands-on techniques, or maybe we can try to work also with to do the techniques with the hands-free. So we also have the benefit of the TECAR therapy and mobilize the area also. And we can work also with long geometry to hold, for example, the resistive probe, and work the elbow and put the plate at the shoulder.
I have a question for you, Malvina. Sorry.
We have many different, yes.
Are you using this kind of positioning of the patient or other kind of positioning? Depending.
I might put this kind of positioning because we can work very well at the whole muscle and also at the tendon and the joint of the elbow, and also we can go a bit higher from the elbow. I mean at the lower arm, so we can have the elbow in the in our therapy center. I mean with the geometry. If we want to do something at the joint, for example, like to mobilize the joint.
Okay,
but we can work very nice with the fascia tools at this position.
Okay, I want to show you something here on our atlas. Okay, so we are on the elbow area. So just going a bit under the skin. I want to show you the typical target of this area. Of course, we are talking about the extensors of the wrist. This is the epicondyle of the humerus. Okay. Of course, as Malvina and Marco says, sometimes, a lot of times, it's not just an extensor problem. It could be a scapular dysfunction, it could be an overload of the triceps and other muscles that are on this area. But it's very common to have this muscle here, that is extensor scapulae radialis brevis. That is a muscle that reaches the third metacarpal arch. Okay. So it's a very long, and as you can see, we got a long tendon part. This is one of the most affected muscles for the lateral epicondylitis. Of course, we can have also a medial epicondylitis from the medial part of the elbow. But we can evaluate, as Malvina said, and I'm going to show you just a simple technique how to evaluate the extensor radialis brevis. And how to treat with the dia blade small. Okay. So with a sit position, we ask the patient to stay in a flex position. Of course, we can evaluate the extensors. Okay. Spingi verso il basso. The pronosupination movement. Verso l'interno. Okay. Gira verso l'interno. Gira verso il contrario. Okay, but for targeting that specific muscle, we go in a flex position of the elbow, radial deviation. We ask for a fist on the to the patient. Okay, radial deviation, and we ask for an extension. Okay, it is very easy to isolate the radialis carpus brevis, okay, with this positioning. So flexion on the elbow, flexion of the wrist, radial deviation, and we ask for an extension. It's very easy to identify because we start to become more precise on the side of the lesion, okay, on the side of the treatment. So after the typical preparation, we use the dia blade small, not on this side. This is very useful for the lower limb, for the calf and the soleus, but for the upper limb, this area, sorry, I put it here, maybe it's better. Okay, this here is very easy. So with just a bit of cream, we put, as usual, sorry, I need to go on the fascia program, fascia, okay, resistive, we set 470 kilohertz. I start with just 40%. The fascial program has a specific current, okay, has not the whole amount of the machine, so I'm not delivering incredible percentage of watts. So the 40%, have a look in here, the amount of power that I'm delivering to the tissue. We are talking about 15 watts, okay? The current is quite a good current. We are talking about 400 milliamperes. Have a look in a few seconds at the histograms, as usual, for better understand the therapeutic window. Also, we can ask to the patients. All right, he perceiving a 2 in a scale from 0 and 10. All right, and after isolating the extensor radialis brevis, I can easily scan the muscle and identify the densification along his direction. All right, I don't want to spend so much time in this, but just for make a practical example, okay, how to set up the machine, how to use the technique. Of course, here we don't have evaluate the full shoulder, okay, but also the TECAR doesn't have any epicondylitis, so okay. Guys, do we have time or not for something on the wrist? I don't know, I asked to Mauro, Francesco.
You have, well, it's 3 minutes 12 now.
Okay.
So it's up to you.
Okay, we are here, so I want to just show you something. Speaking about the carpal tunnel, we can have a straight treatment on the hand, on the transversus ligament of carpus, on the tenar and hypotenar muscles. We can, of course, have to do the right evaluation for identify if it is a straight problem on the carpal area, or if it is a double crest syndrome, or a root problem from the neck, or for example, pronator teres compression. So here we got the ability to evaluate, okay, and treat also the densification, maybe the pronator teres, or just to focus straight on the transversus ligament with a very small movements directly on the over the ligament. As you know, with the carpal tunnel, we have this dizziness, pain, especially pain during night. Okay, we can lose also the muscles when we have the contralateral view with the right one with the left one, for example. And here is very easy, also with very gentle movement. You can see where I put my thumbs, also for sliding on a very small area, very precise over the single fiber. So it's very easy to affect the single fibers. Okay, she's perceiving a gentle warming under the fascia tool. She said me 3, between 0 and 10, okay? So also the histograms, you can see we are using a very gentle current, not so much current. Okay, so also you got the information about the impedance of the tissue. We got 200 ohms, so it means that the resistance between the plate and the active electrode is of 200 ohms. And if we want to increase the temperature, we just can increase the power amount, and have a look at the histograms. I'm doing always the same technique on the carpal ligament. You will see in a few seconds that the histogram starting to change the color, because now we are using 30 watts. Also, I'm starting to perceive some warming sensation on the wrist, for example. We are moving to yellow right now, for example. Also, we can combine the mobilization. Okay. Can also increase. All right, we reach 8 right now, and now we start with the yellow one. Okay. Okay, so guys, what about you? Any questions? Any idea for the carpal treatment with Yastum?
Normally, I used to treat like you do. So after this, if the person have some prestigious or twinkle fingers, I use the hands-free mode and start to doing some neurodynamics techniques.
Wow.
So for the median nerve normally is affected or with a little bit compression. So I put the hands-free mode and ask do some more attention to the person to do some neurodynamics techniques, the ULTT1 and ULTT2. So
nice. Can we try to reproduce here what you do?
Yeah, for sure.
Could be sure, supine position is good.
Supine position, yeah. Or a sit position, but the supine position is good. Yeah.
Okay.
So I put
tell me.
Yeah. Put the one electrode under the carpal.
Under the carpal here, on the hand or on the wrist?
On the wrist.
Okay. Are you using the automatic electrodes or the traditional one? I can say the handle, this one.
Normally, I start with that one you have on your hand. Yeah, and then I pass to the hands-free mode.
Okay, so.
And with the electrode, I stay on the chair, and I like to treat.
I can do that. Okay, I try to do what you are suggesting to me.
Yeah.
So I can start with the traditional handpiece. Okay. So resistive mode. Tell me about frequency, power. Do you have any idea?
The 407. The 470 hertz.
Okay.
Normally increase until 60%. Normally.
How much? Sorry. How many? What about the percentage? Sorry, 15. You said.
50 to 60%.
50 to 60. Yeah, that's right. Because we are using a long geometry.
Yeah. 15 we can feel anything.
Exactly. It's okay. 55 for you?
Yeah. It's okay.
Okay. So a bit of cream, and I asked Federica to grab on his hand. Okay. So she grabbed the handle.
Yeah.
Okay. So, and here we can do some mobilization, you mean? Neurodynamic mobilization?
Yeah.
Nice. All right, so here we are working with 58 watt, 60 watt. Okay, so we are promoting the energy through the whole upper limb, as you can see. Do you feel any warm sensation? Senti caldo? Sì. Dove? Okay, she's perceiving some warming inside the hand. Is it correct?
Okay. It's good.
There is a question about videos. We have not talked about the videos or the fascia tools.
Yeah.
People are asking, Is there any video that we can watch?
Yeah, for sure. Thank you, Federica. Okay. Yes, I'm gonna show you. Well, first of all, thank you, Marco, for this neurodynamic technique, because I think it's very interesting. So we are mobilized. Are you doing sliding or tensioning exercises?
Sliding exercises.
Better.
Yeah.
Okay, I want to show you just about this question of Francesco, something about videos and some information on the pathologies. There are, of course, a lot of videos inside the globus.com on the section online courses. You get different languages, because I know you guys are following us through different countries. Italian, for now we got English, Italian, French, and Spanish. Okay, for sure, on the future, other languages will be added. All right, we get a lot of video, one full course on the use of TECAR GLOBUS DIACARE, and one full course on TECAR therapy. From the really basis, we have really a huge of videos for better understanding, from the basis for knowing TECAR therapy, how to set up the treatment, and a lot of also examples also on myofascial treatment. Let's have a look at, for example, on the chronic cervical pain. Sorry. Chronic cervical pain is one. Okay. I'll just show you a few minutes.
Subclinical evaluation. We'll start by letting the patient get in a prone position and placing the plate under the abdomen. Remember that the skin of the patient needs to be cleansed, and the plate must be covered with a uniform layer of conductive cream to assure good conductivity. We'll start the treatment with the capacitive mode, easily selectable from the Quick Start menu. We bring power to 40% of emission and turn phase, keeping the tool always in contact with the skin to guarantee the closing of the contact, benefit from the therapeutic current, and at the same time perceive the changes in the tissue at every movement.
Okay, guys, I don't want to bore you with this.
Martina has to leave us, so we would like to thank her for staying with us.
Goodbye.
Yes. Martina, you know that you have to go.
Thank you very much.
For your intervention.
Nice to be there with you.
It's a pleasure to have you with us. We carry on just for 2 more minutes for answer some questions, but thank you again.
Okay. Thank you for the invitation. See you again. Bye bye. Bye Marco. Bye Enrico. Bye Mauro. Bye everybody. Ciao.
An interesting question, Enrico. Is the lymphatic system affected at all?
Yeah, well, we can treat the lymphatic system. There are also some specific programs for treating the lymphatic pathologies. Also for upper limb, there is really great results, great effects by treating. The basics are that, first of all, we need to open the lymph nodes, the proximal lymph nodes, then we can start to drain from the distal part to the proximal part. Marco, do you have experience also? Have you ever used TECAR device for the lymphatic pathologies?
No, I haven't, but I think it's if you think about it, it's basically you use the drainage techniques like I don't know, Leduc, and if you think about it, it's programmed the machine for active the lymphatic system, and you can apply with the same technique. So I think with the energy of the TECAR, we can obtain much better results. I only use one time for but it's not the same, but for ankle sprain edema, very acute. The ankle sprain occurs 2 hours before the guy come to me. But we have maybe a 25 to 50% the reduce of the edema. So the TECAR works very well for this kind of condition.
All right.
Yeah.
A very similar question was asked during the first webinar we had. So maybe I invite everyone to have a look at our website, and to visit our website to see the videos of the previous webinars, which are available. There are many available, for all the questions that are being asked during those webinars are still was there. You can see all the interventions that we had, and there are also many other, of course, videos that we will put online and podcast in the future. So please come and visit the website on a regular basis.
Yeah, I see a lot of questions, but I think we can answer later. Yeah, privately, because there is really a lot of people following. I'm very glad about this. Mauro, what do you want to say?
Nothing. We're just finishing our webinar today. As Enrico says, we will answer privately all the answers, a lot of answers that we received today. So just wait for our answer. We are not leave it there. We will follow our answer to all of the questions. And thank you very much for your participation. Thanks to my friend Marco for your time and for your intervention. It was very good, and we thank you very much. And I don't know if my colleague.
Yeah, remember the next appointment is the next Tuesday. We will talk about spine, a lot of also pathologies and examples, and also questions, practical skills, and we will have we are very lucky to invite Chris, the next specialist that will be a part of our webinars. She's also a specialist for spine disorders, so I hope we can enjoy together also the next webinar.
Next week on Tuesday. Don't forget it.
Okay, thank you very much.
Same hour.
Thank you, Enrico.
You're welcome.
Thank you, Federica.
Thank you, Federica.
And guys, see you next time.
Thank you very much, guys, for the invitation. And ciao, ciao. Thank you very much for your invitation. I hope it's enjoyed the webinar as I am. So thank you once again for your time. Okay, ciao. Thank you very much, Enrico. Ciao, Mario. Ciao. Thank you very much.
Ciao. Take care.
Ciao, ciao.